These are my disclosures. My study I will present was supported by Paul and Brown by an unrestricted free grant. I will go back, sorry. And the title of my presentation is Microparticles Contamination. Is it an innocent bystander of our therapy or a real threat? So I will continue to tell you the bad things about our fluids we give to our patients every day. So I was confronted with this question, I think it was like 8 years ago. I was responsible to optimize our infusion management on the ward. So first time I was thinking about microparticles in our infusion solutions. So the normal reflex was that I was looking into the literature, and I will now invite you to follow my way and the way of our center, how we try to answer this question in these 8 years. So the background of particles and intravenous therapy is that we have a lot of data, and the data starts even in the early 60 years of the last century, and they could show that were pathologists that could show that you can find particles in lungs from RDS patients with inflammation around, and research is going on until nowadays, and we have a lot of anesthetists who have spent a lot of time in that research. And for example, Merkens et al., anesthetists from Germany, could prove that in a normal intensive care setting, he could estimate that up to 1 million particles per patient per day are infused by our infusion solutions. Different effects were proven in these research. For example, embolization by these particles, thrombogenic effects, immune modulation, and also impairment of the microcirculation by infused particle contaminations. What is the origin of these particles? And there is one important thing, is drug incompatibility reactions. They account for more than 20% of all medication errors and up to 90% of administration errors who happen in our intensive care wards. They impair the efficacy of the administered drugs, and they increase, of course, the risk of side effects, and sometimes they lead even to a formation of toxic drug components. On an ICU, the co-infusion of two drugs is uncertain in up to 45% of instances in which the compatibility of the drug combination is unknown. That is a high amount. Other sources of particles are, for example, just the incomplete reconstitution of drugs. They are not reconstituted in the right amount of water, or, for example, they are not reconstituted for the time they need to reconstitute. But also in generic formulations, if you just open the bottle, you find a high particle load if you look for it. And our parenteral nutrition admixtures, they cause enlarged lipid droplets, and they arise from the emulsion instability of these mixtures, and also a high amount of calcium phosphate precipitates occur in these solutions. And the last point is that also particles arise from the components of the infusion system itself. For example, roller pumps, three-way taps, if we screw them, they generate a high amount of particles which we infuse to our patients. What can aggravate these factors? And this is mainly the quantity of the administered drugs and the complexity of the infusion regimen. It is the lack of available intravenous lines, because we cause more incompatibilities if we combine different drugs in the same lines. And it's also the lack of incompatibility informations for the administered drugs or their formulation. So there are different programs which can help to have a good standard in your infusion therapy, and to just try to prevent our patients from these particles by preventing incompatibility reactions. And what we have done then was that we introduced inline filters in our infusion management, and we looked via electron microscopy on these filters after use on our PICU. So we first examined 20 filters of different patients, and after 27 hours of use on our PICU, and the average number of particles found just on the surface of the membrane was 542 per square centimeter. But more than 20% of the examined filters showed signs of the beginning blockage. So they were just blocked by large particles, which just were counted like one particle, but being a conglomerate of thousands of different particles, for example, if you use parenteral nutrition. These are some pictures of these particles we have found on the membranes. These are glass particles. After 72-hour use of this filter, we examine it by electron microscopy, and this is just from one patient. It's a 17-year-old girl after a aortic valve replacement. And all these glass particles came obviously from breaking of glass ampoules and the fluids the patient afterwards get via the central venous line and via this filter. This is the size of a lung capillary in relation to these particles. You often find very large glass particles, so they cannot trespass the lung, and you can imagine, if you see those particles, that they hurt the capillaries and obstruct them and lead to embolization of the lung capillaries. 70% of the demonstrated particles we found on the surface of the membrane were larger than a pulmonary capillary. This is a picture of another filter we used on the ward, and this is one of a parenteral nutrition, and you see it's almost blocked by a large particle or conglomerate of particles, and this is from a patient after autotopic liver transplant, a neonate, and he obtained parenteral nutrition with a high osmolarity. We are very low flow rate, 5 mils per hour, and after 72 hours, this filter looked like that in the electron microscopy. This is the examination summarized, and you see, if you have a look, you see here the particle load, and there the applied components via the filter membrane, meaning more than 6, meaning 6 different medications were given over the filter, so you see a slight increase of the particle load dependent on the complexity of our infusion regimen. But you also see here's just a single drug. We have generic drugs who have an inherent very high particle load. This is, for example, zomzanid, gamma acid, butyric acid, we use for sedation in some patients. But what about the clinical data, about the influence of intravenous particles on the outcome of our patient? And this is a bit neglected. You cannot find much in the literature. So this we were very astonished about, because there were some of these good studies I told you before that particles are really there, but clinical research is missing. But there are some good animal models who could prove that the microperfusion is impaired if you, for example, just flush antibiotic preparations with particle load into a muscle, for example, or in different organ systems, also published by anesthetists from Germany. Some of the studies could also show a reduction of thrombophlebitis by the use of inline filters after the elimination of particles. And there's just one study from Falchuk et al. From 1985. This study is published in the New England Journal, and this is the only double-blind study regarding inline filtration and retention of particles from infusion solutions. Then there was the year 2005, and your neighbors from Dutch, they could prove that typical neonatal complications like inflammation, sepsis, and enterocolitis could be prevented by the use of inline filters and the retention of particles and air from the infusion fluids. So this was the starting point. When this was published and I read it, I was thinking about maybe this is also important for our patients, because we have a lot of patients with sepsis, we have a lot of patients with SIRS on the ward, because we have a cardiology ward, and we have a lot of patients after cardiac bypass, and then they are suffering really under systemic inflammatory response syndrome. So we focused on that, and this is the results. So he could show that sepsis and clinical sepsis was reduced, and the summarized complication rate was significantly reduced in these 88 neonates who were randomized to filter or non-filter group, and this was slightly significant. So we started, the next step was just we have seen we have particles, we have seen we have obviously problems with that, so we started the inline filtration. Now we wanted to know whether this had a positive effect on our patients. So we started a prospective randomized clinical trial for the use of inline filters in critical ill children. And this is the study design. Study is already finished. Prior to the study, we optimized the infusion regimen to prevent precipitation and incompatibilities of drugs and solutions. We randomized pediatric intensive care patients to either control or intervention group. Interventional group receiving inline infusion filter throughout complete infusion therapy until they were discharged from our ward. All solutions, all medications, inotropes, everything was filtered, and the study was open label. The primary endpoints were a reduction in the incidence of severe defined complications, and the study was powered for a reduction in the overall complication rate. This is the comprehensive view on our infusion setup, and you see we placed filters on every infusion line, also for sedation, for heparinization, for the short infusions, for parenteral nutrition, and also for the inotropes. And this is the results. There we had a Gaussian distribution of patients to both groups. We had no differences in PIM score. The PIM score is the score like the Apache for the children, pediatric index of mortality score. Median age was the same, weight or gender distribution was the same. We have a heterogeneous background of disease with no significant differences in filter group and non-filter group, being a good picture of the patients we have normally on the ward. You see it here. We have a lot of cardiac disease. This was the largest group in the study population. And these are the results. We could just achieve with this simple intervention to filtrate all of the infusion solutions a reduction of these complication rate from 41% to 30.3%. So, and this was statistically significant, and 807 patients were randomized, 401 in the filter group and 406 in the non-filter group. And we also see by these effects a slight trend to a reduced mortality. And this was mainly triggered by a reduction in the incidence of SIRS, which was really consistent over the whole stay on the ICU. And you see all other organ failures were reduced, but only SIRS and the overall complication rate, the study was powered for that, reached statistical significance. What was the clinical effect? We could reduce the length of stay by inline filtration as secondary outcome, like 20 hours and 3 hours shortened mechanical ventilation in the patient who obtained filters. And what was the trigger for that? Because we don't see any effects on the organ failures, we have a close look on organ dysfunctions. So we see that respiratory dysfunction, renal dysfunction, and hematologic dysfunction was, in this secondary analysis, reduced by the use of inline filters. So I summarize. Particulate contamination of infusion solution represents an additional risk for intensive care patients. It's not a real threat. Particles seem to influence the immune reaction, and we can lower the incidence of SIRS, reduce the length of stay and mechanical ventilation if we use inline filters. Therefore, inline filtration offers a new therapeutic option to reduce complication on the ICU. And our ongoing analysis focuses on subgroups and economic effects of filter use. And we are very vulnerable for new therapeutic options. And if you believe or not, sometimes a horse can improve the outcome of our patients.